Good afternoon all. Yes, good afternoon. Mr. Gale.
Thank you, my lord. Next witness is MacDonald. She represents the Scottish Healthcare Workers Coalition. The reference to their statement is SCIWT 0465501. And it's been agreed for purposes of today that I will refer to the witness as Cass. So Cass, you provided us with a statement on behalf of the Scottish Healthcare Workers Coalition, and you are, as I understand, agreeable that that statement will be the evidence on behalf of the coalition, together with the evidence that you give in amplification of that statement today.
Yes, that's correct.
And you're agreeable that your statement is published and that the evidence that you give today is recorded and broadcast.
Yes.
Now, can I make just two preliminary observations? You've provided us, as is apparent from your statement, with a lot of very carefully researched footnotes. And for those of us who don't particularly like working from a screen, that's volume 1 of your footnotes. That's volume 2 of your footnotes. So these footnotes largely relate to issues surrounding long COVID.
They're quite broad-based. Some of them relate to pieces of work that have been done. Some of it is national guidance. So it's quite broad. I believe some of it is actual scientific research that's been done as well. So it's quite broad, but a lot of it does refer to long COVID. That's correct.
And I think from our perspective, we would like to thank you very much for putting that repository together, because that does indeed help with the work that the inquiry is doing, particularly in relation to long COVID.
Yeah, I think it's a great deal of work by our legal team and also the wider group, as opposed to myself specifically. So thanks really need to go to everybody, I think, who put time in.
Well, thank you very much. The other observation I'd like to make is that in connection with your statement, we find at several of the introductions to each section that you quote from individuals generally who have been affected with long COVID. And again, those quotations, having gone through some of your footnotes, I found those quotations within the material, within the footnotes. So could you just indicate how you chose the various quotations and what was their purpose?
We chose the quotations because we felt that they were very, they really spoke to what we were trying to say within those sections. They were real life examples. They were, for the most part, given anonymously through work that the Scottish Healthcare Workers Coalition has done, and they also came from a report that the Key Worker Petition Campaign did last in March 2023, which of course I'm also involved with. So most of them are anonymous. I think some comments came from one individual who I know personally, but they gave their consent for them to be included within the work that we were doing because of the importance, but they've asked to remain anonymous, and I wish to respect that.
Yes, indeed. All right, thank you. Now, could I ask you a little about your own background? And in particular, we can see that you're here in a wheelchair. Could you indicate how you've come to be in that situation, and in particular the origins of your health condition insofar as it relates, I think, principally to long COVID?
It's fair to say that I had some underlying but well-controlled chronic conditions like asthma prior to having COVID. I contracted COVID in April 2020. I believe I contracted it at work. Unfortunately, it has got to know me in a long and personal way. I was largely healthy prior to COVID. I had some mental health issues. I have hypermobile Ehlers-Danlos syndrome, so I have chronic pain syndrome, but they were very well controlled. But since I've had COVID, I've developed a cardiac arrhythmia. I've developed a condition called postural orthostatic tachycardia syndrome. I was diagnosed with moderate sleep apnea last week, which they believe is secondary to dysautonomia, of which POTS is a version. I have been diagnosed with myalgic encephalomyelitis, ME, chronic fatigue syndrome, in addition to long COVID. I have been in daily severe pain since June 2020 as a result of my COVID infection, and I've been diagnosed with functional neurological disorder. I have problems with my short-term memory. I've had to rest aggressively to be able to appear today because I'm very prone to what people like to call brain fog, but I refer to as cognitive dysfunction because it's like my brain is trying to wade through treacle. I sometimes have problems with my speech, with concentration, with understanding. I'm no longer able to speak foreign languages, and I have been speaking foreign languages since I was over 40 years, since I was a child. So, and that's probably not the entire extent. It feels like every day something new crops up, and I have an allergic condition called mast cell activation syndrome as well, which has even affected my diet, and I have a lot of medication I am now on.
I think I should point out that should you feel that you would like a break at any point in time as you're giving your evidence, please tell us.
Yeah, thank you.
And arrangements will be made. You said you were working prior to the pandemic, if I can use that as a point in time. So prior to 2020, what were you doing?
I was a Band 5 nurse. I've worked for my employer since 2012, NHS Lothian, and started in theatres, went to sterilisation, decontamination, and I was working within the wider infection prevention control team as an audit and surveillance nurse, gathering data for national surveillance programmes.
When was it that you found you were unable to continue with work?
The last day I worked was the 8th of August 2021. I tried several times to go back to work after my infection in April 2020, and my contract was terminated in August last year, 2 years to the day since I'd last worked, and I'm now medically retired.
Right. Okay, thank you. There are one or two things you've already mentioned that I'd like to look at in a little bit more detail. But a consistent theme throughout your statement is long COVID and the implications that has had for you personally, but for many within the group that you represent. Is that correct?
Yes.
Yes. Now, one of the points you make really at the beginning of your statement is that long COVID is not or should not be taken as synonymous with an extended or delayed recovery from COVID. Can you explain why you say that?
That is possibly best explained by medical experts, for example, Claire Taylor in it. However, the way I understand it is this is a chronic condition that has arisen as a result of post-viral complications, be they obvious or not obvious at the start, that is currently not able to be treated. I believe it is a disease in the same family as ME, chronic fatigue service. which therefore means that this is potentially a lifelong condition. I know some people, I believe it's a relapsing, remitting condition. I have good days and I have bad days. I have good periods and bad periods. And I know that people have believe they've made a full recovery. Others believe that while they've got a lot of function back, that they have not. So I believe this is potentially lifelong, and as currently we cannot treat it.
Perhaps I was perhaps pointing to something perhaps more simple in this. Perhaps, and it may be the way I took the expression, that the suggestion of, which we've, I think, in the general public, and one does hear that, oh, it's just your recovery has been delayed a bit. It perhaps lessens the significance of it. Is that something you would agree with?
I know people think we're just a little bit tired. I've now been ill for 4 years. 4 years, 2 weeks. And there's no sign that I'm improving. In fact, I believe, I'm hoping I don't get any worse. I don't think that's a long recovery, and I don't think the general public realise the full extent of the issues and symptoms that many of us are having to deal with.
One of the points that we've come across, really from the outset of our hearings into the pandemic, and in particular into long COVID, is a widespread scepticism, particularly in the public domain, as to the genuineness, if I can put it that way, of long COVID. Is that something you and your colleagues have come across?
Very much so. I think we would say that we've experienced this from fellow healthcare professionals. Some of us have experienced abuse online. A big factor of some of the abuse that we get is that people insist that this is a vaccine injury, it's our own fault, or it's related to, you know, perhaps we were overweight and we clearly must have had something wrong with us. So it's a lot of ableist victim blaming. But the vaccine injury thing is quite a big thing, even for those of us who were infected before there were vaccines.
I think one of the things we do occasionally hear is that you're lazy.
Yes, lazy and not trying hard enough.
Yeah. Good bit of exercise would do you the world of good.
In my case, that would make me extremely unwell, because when I stand up, my heart rate hits the hundreds, and I can pass out. And I can't really walk very far anyway, which is why I'm in a wheelchair.
Could you tell us about the Key Worker petition campaign?
I can. I formed that campaign in 2022 with a midwife friend of mine from Wales and a fellow nurse from Devon. It's a grassroots campaign that is seeking a compensation and pension scheme along the lines of the Armed Forces Compensation Scheme for all key workers, regardless of whether they were in healthcare or even stacking shelves in supermarkets, who have occupational long COVID.
Well, I think this is a campaign that is UK-wide.
It is UK-wide, and last year we handed in a 125,000 strong petition to Downing Street.
Where is that campaign at the moment? How is it progressing?
We're not a big campaign team. We obviously are engaging in work, and my role at the moment is I'm working with the Scottish Healthcare Worker Coalition on behalf of healthcare workers in Scotland, and this is kind of part of our more broad remit. We're not very well people, so unfortunately sometimes we have to fight which battle we can.
I'd also like to ask you about the Scottish parliamentary inquiry into long COVID. How has that been progressing?
Sorry. So that was this COVID-19 Recovery Committee. It was a specific committee decided to open an inquiry into long COVID because of concerns that they had. And the inquiry closed and a report was published, and there were an awful lot of people who gave evidence from within Scotland and also around the United Kingdom about the experience of individuals with long COVID, their access to health and social care services, amongst other things. And a big feature that came out of that was the lack of information and data that existed on the scale of long COVID.
We'll come back to some of the data in due course, but has that improved?
No, I don't believe so. As far as I know, the UK government has stopped counting even COVID cases. Data is essentially based on a lot of people self-reporting their symptoms, and we as a group have been engaged in trying to gather information using freedom of information, and we have found it extremely difficult to get information back from employers about COVID infections, the scale of long COVID, and so on and so forth.
Okay, thank you. Paragraph 7 of your statement, you say that the coalition, I'll abbreviate it to the coalition, contends that the consequences of the handling of the pandemic have been borne unfairly and disproportionately by Scotland's healthcare workers. Do you explain that in a little more detail for us?
From some of the information we've been able to gather from the Office of National Statistics and the limited data that they've gathered, key workers, healthcare workers and social care workers in particular have had a much higher incidence rate of long COVID. I also remember from the BBC Panorama programme, Forgotten Heroes of the COVID Frontline, someone who sits on the Industrial Injuries Advisory Council, I think it's Council, said that when they actually looked into information, healthcare workers had double the risk of contracting COVID and double the risk of dying from COVID. And obviously as a population group, our exposure to COVID being higher has meant that we have a higher incidence of long COVID, and that is backed up by limited data within the ONS. I think the average population, I think it's of everybody who's had COVID, I think it's something like 3.4% have long COVID, but the rate is above 5% for healthcare workers.
Yes, I've seen those figures. You juxtapose, I suppose, the work that healthcare workers carried out prior to and during the pandemic, and you say that that work was carried out, as you put it, at exceptional risk to ourselves. And then you go on to say that the Scottish Government and the NHS health boards failed to properly manage and support healthcare workers, placing them in harm's way and at unreasonable, unconscionable, and frequently avoidable risk of serious harm to their health. I realise that is a summation of what you go on to develop. But those are very, very striking criticisms. And in fact, you do go on to level a charge of negligence against the Scottish Government and the NHS health boards. Now, can you just give us a little more flavour as to why you are so critical of both the government and the health boards?
My feeling is that they were completely unprepared for the pandemic. I believe that guidance that was handed down, that was being passed on to us, was flawed, and it was not based on emerging science. I know of incidences where staff within health and social care who had underlying health conditions, there were huge delays in their being assessed by occupational health. My understanding is that in some areas, it was only specific for example, it was only if somebody was pregnant or had diabetes that their own manager was required to do any assessment of them. Everything else was expected to be done by occupational health. In my own case, it wasn't until 6 weeks after I had my COVID infection that I finally had my occupational health risk assessment, my COVID age assessment. I believe that as a result of being so underprepared, there was a lack of availability of both PPE and respiratory protective equipment, and I believe decisions made to only use surgical masks in certain situations when caring for COVID patients was very much flawed. I mean, we could spend probably all day on this, but also it was at a time when asthmatics in Scotland were all being told to shield. I was being told that NHS Scotland had done a risk assessment and it was perfectly safe for me to attend work, but I just shouldn't, even though I was a non-driver, I just shouldn't use public transport because that wasn't safe. And I've never been given those pieces of guidance which I was told came from NHS Scotland.
Right. You said that the guidance was flawed, and again, you put that in general terms. Can you provide us with some specifics in your view as to how the guidance was flawed?
It was based on an assumption that COVID is spread by droplets, and that guidance does not appear to adequately take into account, well, what we believe and what the emerging science says about COVID, which is that it's airborne, and you have people like, I think his name is Julian Tang, he's a consultant virologist. He was warning that this appeared to be airborne in April 2020. And it didn't seem to take into account any issues around ventilation. I mean, we don't have HEPA filtration or the numbers of people who would be in a room. If you have a lot of people coughing in a room, there's going to be an awful lot of droplets in the air, even if you assume that it's just droplet spread. But we think it's airborne.
So one of your particular criticisms, therefore, is in relation to what appears to be a presumption underlying guidance, which was that the means of transmission of COVID in the early days of the pandemic was by droplets rather than airborne transmission.
Yeah, initially they were using RPE if you were looking after COVID patients, and that changed quite suddenly. We think that decision may have been taken by individuals in Scotland, but we are not sure. I know that we have submitted evidence. There have been individuals like David, there's an individual I know from...
Can I ask you not to mention names, if you don't mind?
Who has done quite a bit of digging. That appears to perhaps have had its source in Scotland, the change in, this push to change it to, it must just be droplets, we'll just wear surgical masks. That appears to have originated in Scotland and then was subsequently picked up by the Four Nations infection control advisory body, because it became an issue of all Four Nations were using the same guidance.
I think we've heard evidence, Cass, that I think from particularly representatives of the RCN, that they were campaigning, if that's the correct word for it, advocating for the fact that the principal means of transmission was airborne rather than by droplets. That they were doing that really from the outset of the pandemic, so from March 2020 onwards.
Yeah.
Were you aware of that?
I was certainly aware that a number of individuals were looking at pre-existing information that existed on similar viruses, similar coronaviruses, for example, SARS and also MERS, Middle Eastern Respiratory Syndrome. I was actually asked to look into if I would look up articles by my manager, which I did, and I came to the same conclusion that the RCN later came to with their literature review of all of this, which was that respiratory protective equipment, so your FFP3 masks, and so on and so forth, gave, well, there seemed to be a less, if you look at compare them to the individuals who just wore a surgical mask, they weren't getting infected. And then a study was done at Addenbrooke's Hospital. They had a standard COVID ward. They gave all of the staff FFP3 masks. None of their staff contracted COVID from their work. And I know that the RCN have referred to that study. Whereas with surgical masks, there seemed to be a higher risk of infection. I suppose in that case, it has come down to interpretation. It's come down to interpretation of pre-existing science and the science that has obviously emerging science since COVID.
Yes, I think that's one of the other points I was going to ask you about, because you did say that you level the charge against the government and against the health boards on the basis that there was insufficient regards paid by them to the emergence of developing science. Now, is that all in connection with this idea of airborne as opposed to droplet transmission?
Yes, and I think also it's partly to do with they at all points seem to have failed to consider that that what turned into the pandemic would leave a significant number permanently disabled. That has happened with SARS. There were people speaking out about that at the start of the pandemic, particularly in Canada in March 2020. There was evidence from SARS, studies taken, I think 2010, so a significant time afterwards. We knew that people were suffering from long-term effects. At that point, 7 years after the SARS epidemic, they knew healthcare staff had been disabled by swine flu back in, I think it was 2008 or thereabouts in the UK. There didn't appear to be any consideration paid that could be a possibility, and therefore with a novel and unknown virus that they simply did not know what the long-term effects would be, I don't think they paid enough attention to that, no.
All right, thank you. We heard a little bit the other day from Mr. McCurdy of the Royal College of Physicians and Surgeons in Glasgow, talking about AGPs, which you also mentioned in your statement. And there was obviously an implication for both the mask wearing and the wearing of particular types of masks. So can you explain why and in what circumstances there would be a justification for wearing different types of mask?
Well, I'm not the person who made the decision about what was an aerosol generating procedure. For some reason, somebody decided that coughing and speaking were not. And at the early point of the pandemic, we know that choirs, for example, were banned because of outbreaks of COVID. Essentially, there was a list of procedures. So, for example, intubation, suctioning, and so on and so forth.
Yes.
Some were not on that list. There was quite a bit of debate. I recall people arguing with my colleagues over it, that what should and should not be included, and that was not something we had any, the IPC, the infection prevention control nurses, had any control over. You know, we were working under guidance that was changing all the time. But yes, so if you were dealing with an arrest situation or you were intubating and suctioning, you were supposed to wear an FFP3 mask or similar. But for everything else, even if the patient or patients were coughing, talking, etc., you wore a surgical mask.
Another point you make is about fit testing masks.
Yes.
Now, in the more general sense, we've heard evidence in the inquiry about one of the deficiencies, I suppose, in the provision of PPE that it was designed for your average male. A lot of it was not designed for or to fit the average female face. Is that one of the difficulties that we've had?
I'm not a manufacturer. I've never been involved in a manufacturer. I have been involved in fit testing, and I do happen to know that it would be a procurement issue as to why the wider Scottish procurement services pick particular kinds of mask, and they tend to pick the ones that will fit most people. I believe 3M, Aura, and also Alpha Solway were two companies that provided quite a broad range of masks, although at some point some were discontinued during the period that you were talking about, and they had to find substitutes. I think the bigger problem is actually around fit testing itself. In my experience from a different scenario, when I was working in theatres, when people were concerned that Ebola would make its way to the United Kingdom after a Scottish nurse was infected, they realised that a huge number of staff had never been tested within the organisation as a whole. Many of them had never been retested. I would imagine that was the case. Certainly when I joined the organisation in 2012, I was not fit tested. Some of this could be down to time, some of this could be down to having the skill set to do that. So I believe a huge part of the problem would have been that staff simply had never been fit tested or had never been retested, and I don't know if they've ever solved that particular issue.
Again, looking at the generality of what you say, at the beginning of your statement, paragraph 8, now this is perhaps a reflection on what you've said earlier. You say that you and your colleagues did our job, but now we have been disabled. We feel abandoned and forgotten by the government and the healthcare systems we worked for. Now, I know you go into more detail, but could you just explain the effect of that feeling that you have upon you?
I know people who are lucky enough to still be employed and who are having significant problems in trying to access reasonable adjustments at work. They are experiencing ableism and unconscious bias. And I would argue that is institutional. It is a long-standing problem, certainly within the NHS and probably within other sectors as well. And for those of us that were struggling to keep up, assuming we managed to get reasonable adjustments, some of us were told, though this was short term, we wouldn't get this for the long term. We had to deal with attendance policy being used against us. If we have chronic conditions, we're going to be off sick more. However, we're expected to keep up with those who don't have those conditions. I know people experience bullying. And for those of us who simply haven't been well enough, our contracts have been terminated. I do believe in some cases it was because simply they were being told you can't keep up with the terms of your original contract. I discussed with my union rep many times about how organisations did not seem to be evolving with the pandemic. They did not seem to be looking at roles, changing things up so that they could attempt to retain experienced staff. However, it seems to be if you can't keep up, there's the door. And I've been very lucky in that I've managed to get certain benefits. I've been able to medically retire at Tier 2, but I know a lot of people who are having their applications for ill health retirement turned down. They're having applications for benefits turned down. There's a lot of delay and they are experiencing financial distress, something I know extremely well from the whole of 2023, my own personal experience, up to the point that many are at risk of losing their homes. Some have lost their homes. They've lost their income. We've lost our careers. And particularly in the case of some of them, like nursing, that's a vocation, it's a huge part of who we are. You know, and we've lost our health, I've lost my mobility. It's very difficult to come to terms with. And we don't know how long this will last.
No. In your own personal case, have you been given any indication as to the long-term prognosis?
Poor. I'm not expected to ever work again. I came off the register last year. I could not re-register with the NMC, Nursing Midwifery Council. And I am not, there is apparently nowhere to refer me to, and I am now been waiting for a year to see a social worker to get additional support. I'm waiting for research, basically.
Right. It's not something I normally do, Cass, with witnesses, but I am going to, with your leave, make an exception. How old are you?
48.
Okay. Thank you. You would have presumably expected to work for at least another 12 years.
I would have probably wouldn't have left for another 20 years, actually. I fully expected to work until I was 67, perhaps beyond.
Okay. Right. You make a point in your statement about clean air, and it's
Yes.
something that you have referred us to. Obviously, this is something that the inquiry will be considering in some detail at an appropriate point. But taking the matter briefly, it's your contention, I think, that the Scottish Government should match the CDC standard, which is the American standard in relation to clean air. Is that right?
Our contention is that current ventilation standards need to be improved because it's been some time since they were last reviewed, and that clean air measures need to be brought in, particularly to health and social care. They are slightly separate but very closely allied issues.
Okay, thank you. Can I also ask you a little about the occupational health and workplace support that you refer to in your statement? I should say, and I should have said this at the outset, I apologize for not doing. There are parts of your statement that we will take as read simply because we need to concentrate on certain aspects of your statement. So please be assured that everything within your statement will be taken account of. But I would like to look at some specific areas. You note that in paragraph 22, that occupational health support has been variable across health boards, with common themes suggesting under-resourcing and underfunding, with many experiencing long waits to be seen. Can you give us a little flavour of that, please?
Occupational health has obviously always existed. At the start of the pandemic, occupational health took on a role for obviously testing staff at a time when testing within the wider community was not available. And all of a sudden, occupational health departments had to deal with an influx of staff members who were unwell. And each employer, I believe, would have taken a different approach depending on their resources. I know that Greater Glasgow and Clyde NHS chose to set up a lifestyle management course for their staff members affected by long COVID. But that was not nationally rolled out. I actually wrote to Scottish Government about this. They told me it was an employer issue. I wrote to my own employer about this course, And they told me that they did not have the resources to do this, and they pointed me to what they did have, which was counselling and physiotherapy. I do also know that I believe they were having, it's my belief they were having, that my own trust was certainly having to ration support. Prior to the pandemic, if you had a chronic condition and you were off work, you might have seen occupational health more than once to see how you were. That was different at this point. You really would only have access to appointments if you were ready to go back to work and to discuss reasonable adjustments, or if they were making a decision about whether or not you would be able to work again in the near future and whether your contract should be terminated. That's my belief.
Support within the workplace, obviously from a managerial level downwards. I take it that that was also, in your experience and in the experience of your group, variable.
Very.
And was that level of support affected by the level of skepticism about your condition?
I think there's probably multiple factors. It probably would have been related to what the organisation was able to offer. However, although the Equality Act does provide that reasonable adjustments should be made available where they're reasonable, it can be the case that a manager refuses to put them in, or they are time limited. You can also, a lot of people have been dealing with ableism and so on and so forth. You know, this can range from, you know, somebody saying, I really need a specific schedule, you know, at work, a specific rota, and being told, well, that's not fair to everybody else, which is a bit tricky. You know, even accessing perhaps equipment that may have been bought for you, for example, you can have some limited equipment bought for you, like chairs and so on and so forth. But I know that some people have really struggled with and continue to struggle with their managers having to involve their union. And I know that you know, that in some cases they've attempted to remove reasonable adjustments like working from home without the best of reasoning. And obviously, if you're trying to go through this and fighting for this to try and stay working, this causes stress. And unfortunately, that's emotional exertion, and that can impact on and bring on symptoms.
You did give us an example, I think you alluded to it earlier. Again, in your own circumstances, you're asthmatic.
Yes.
You were, in your job, not, as I understand it, given the opportunity to shield.
No.
And effectively were asked to come in.
Yes.
As an asthmatic.
Yes.
Presumably on public transport.
Yes.
And to not have the same degree of protection that a general member of the public would have.
I'd say that's fair. We can obviously discuss that more when I return to give my individual testimony.
Okay. Now, could I ask you a little about the access to social care, access to health and social care section of your statement? It begins at the numbered paragraph 32, but you give one of your quotes before that. And you refer to some of the data that we have, or that you have, and you give the figure of an estimate of 91,000 Scots are currently suffering from long COVID. And I think you give the source of that data. And I think we've also heard a more rounded up figure of 175,000, which I think comes from the general, just simply taking the figure which is thought to be for the whole of the rest of the UK, and simply applying that to Scotland. Now, there is similarly an importance of the prevalence of long COVID amongst women, and also the importance of the prevalence of COVID, long COVID, on those of working age. These are factors that you point to in your statement as emerging from the data. Is that correct?
That's correct.
And I think one of the things we have heard from certain witnesses about long COVID is that the idea that one had to have some pre-existing health condition which rendered you susceptible to long COVID, or alternatively, that you weren't somebody who was particularly active. The examples, or many of the examples we've heard of, are people who were very active in their life prior to the emergence of long COVID in their condition. You're nodding.
Yeah, I would say so. When it came down to shielding, it was exceptionally prescriptive. You had to have one specific condition. It did not seem to give points if you had a range of conditions, for example. And when you talk about the data and you talk about the numbers, the studies, obviously it's an estimate. Nobody seems to be accurately counting the numbers, and a study will only look at the specifics of those they are including in the study. So, for example, in some cases it was, did you have a positive test? Well, that excludes an awful lot of us in the very early days of the pandemic because we could not access testing. And again, we talk about the self-reported, but this is an issue that has been identified with the long COVID report that was done by the COVID-19 Recovery Committee, which is data is lacking. And again, we've tried to find out information about reporting and so on and so forth, and we've hit a brick wall.
It's perhaps something that I've returned to on a number of occasions. At the bottom of paragraph 33 of your statement, you talk about that people living with long COVID frequently experience stigma. You say including gaslighting and psychologizing from medical professionals.
Oh, yes.
Right, tell us about that, please.
I know of individuals who have been flat out told by healthcare professionals that long COVID does not exist. More widely in the community, but also involving members of our group. I know that people have had referrals to services turned down because it mentions post-COVID or long COVID. I had a registrar tell me to my face that my condition was entirely, well, basically it was psychological, despite and related to, I believe the words she used were childhood trauma, which is kind of interesting because it never affected me to this degree, and certainly not like this, and it all seemed to come on since COVID. I know many people have experienced issues with certain specialities like cardiology, and we're not getting support for a condition called postural orthostatic tachycardia syndrome. The only clinic in Scotland has now, well, they've stopped funding it. It's been, I know doctors and nurses who have faced being told that this is all in their heads, that they just need to exercise their way out of it by fellow healthcare professionals. And I think while those of us who were disabled before the pandemic had faced a little bit of this, I think it's been a rude awakening to a lot of people who've never been in this position before.
I think if one reads the newspapers, listens or watches the news, rarely a week goes by without something being said about long COVID in terms of further research being done, Got something here, large-scale phenotyping of patients with long COVID post-hospitalization, which somebody very kindly gave me the other day and asked me to read, and I will. But that came out very recently. With this continuing publicizing of long COVID, has that affected the skepticism and the stigma attached to long COVID in your experience?
In my experience, I'm fairly belligerent, and I tell people how it is, you know, and I explain what's happened to me, it's really difficult to say. I know that people are still experiencing problems with their GPs. I know people are still experiencing problems trying to access healthcare. It's the funding that the Scottish Government has given is inadequate, and most of us are not seeing that as change in our day-to-day lives. Mm-hmm. I know people would rather that we stop talking about long COVID. However, there's millions of us around the world who have this condition, and many of us are unable to work, and as many of us are key workers, that's having a massive effect on public services and as a result the wider economy.
You've just mentioned I suppose the gatekeepers to treatment of long COVID as GPs. Are GPs, in your view, sufficiently or adequately aware of long COVID?
I feel for a lot of GPs. I do believe, because I know of individual experience, that there are some GPs who don't believe long COVID exists, or agree it exists but are unwilling or unable to refer on. I know from the experience of others that GPs are very frustrated because the pathways for referral to try and get us assessed or any kind of support simply aren't there. Some of us, if we qualify to access certain services, like for example MECFS services, which again are a postcode lottery, find that this support is very much short term. And a big problem, I think, for a lot of healthcare professionals is that even though we do have training for long COVID, varying quality and so on and so forth, we have GPs who are massively oversubscribed, under-resourced and underfunded. They don't necessarily have the time to stop and do training. That if you ask any healthcare worker about, you know, if they're able to get their protected time for study to further their own knowledge and obviously for their own development and for their registration, they'll tell you most of them are doing it on their own time because they're not able to access the protected time because of the pressures they are under. So I believe it's multifaceted. Having the training there is all well and good, but if you don't have the time to access it, then you're not going to be able to learn from it.
I suppose also taking the matter on from the level of the initial consultation with the GP, if one is then looking to specialist level treatment, I think one of the points you've made is that that can be piecemeal. Now, I take from that is that if you present with a particular problem in the context of long COVID, you could end up being sent to a specialist who is a specialist in one area rather than a specialist who has a more holistic approach to it. Would that be correct?
That's correct. Many in the long COVID community in Scotland have been advocating for clinics where there is a multidisciplinary team approach in terms of assessment, because at the moment GPs have to refer into individual services. So this is multiple referrals, multiple pathways. That's exhausting for the individual to deal with. There's, you know, a lot of appointments, answering the same questions, undergoing tests, but then that assumes that the GP can actually, that there is a service for one of your particular problems. And that obviously takes up a lot of GPs' time because they have to do all of these referrals. You'll have to go in and talk to them. It's taking up unnecessary time when it could be much more streamlined.
And perhaps inherent in what you've just said, delays.
Yeah.
I suppose if you are referred to one specialist and then to another and then to another, there will be an inherent delay in that. But also, there are presumably just delays in the whole service.
There are. There were a significant number of vacancies before the pandemic. As a result of the ongoing pandemic, we have lost staff due to COVID and long COVID, and some people have left the service because of the psychological toll that the experience took on them. So there were long waiting lists beforehand, and now you have an awful lot more people who are being added to existing waiting lists, waiting to be seen. But I don't believe that enough funding has been given to existing services, let alone creating new services to take into account of all these people who, for example, now have cardiovascular issues and so on and so forth.
Could I take you on to the psychological impact? And you begin this after a lengthy quote from one of your members, I think. You take this up at paragraph 37. If one goes back to the quote, the person who's provided that quote observes that the suspected route of transmission, or observes the suspected route of transmission. And the speaker says that he or she considers lack of information to have been, and I use the quote, irresponsible and dangerous.
Yeah, find out.
Now, is that something that is one finds in many of your colleagues within the group, that they feel that there was a lack of relevant information?
It was an extremely difficult time. I know from sitting in an office and checking that the guidance was changing almost, sometimes it could be changing twice a day, even if it was minor changes. You perhaps also would have policies making decisions about where they were sending patients, and this is something that I am aware happened, that even, not just between health boards, that it was a case of information perhaps was not being passed along about a patient when a patient was being transferred. I do know that one such situation led to a huge outbreak in which 26 healthcare staff were infected as a result. I wasn't on the wards myself. My job was very different. But I do know from what friends who both have COVID and didn't have COVID have spoken of. And for some of them, what they saw and experienced, it still sits with them today, and mental health services have a very long wait for people to be assessed and seen.
That leads me on to one other thing I'd like to ask you about, and that's counselling. What is your view on the availability of counselling for long COVID sufferers?
If you are a member of a union, you can probably access short-term counselling. You may be lucky enough to have an occupational health service that can refer you again for short-term counselling. However, short-term counselling, it's like putting a sticking plaster over a major venous bleed. Short-term counselling, I am now on a waiting list to be assessed for complex post-traumatic stress disorder, some of it related to my COVID experience. I suspect a lot of my colleagues also may be suffering from PTSD as a result of their pandemic experiences, and the waiting lists to be assessed by community mental health teams for this, and obviously wait then for treatment, they're very long. We've known this for a very long time, that there are issues accessing timely support. And short-term can be helpful for issues that are ongoing in the moment, but when trying to deal with things that require long-term treatment, it is. It's a sticking plaster. It's not a solution. And if you have an awful lot of people who need to access those resources, you're going to have to wait for them.
I suppose one of the other issues is the availability of counsellors.
Indeed.
Can I also ask you about pressure that members of your group have experienced in being, using your expression, pushed back into work? Can you explain what information you have about that and why it was occurring?
I know of individuals who have been pushed back into work, forced to use up their annual leave for sick leave. You know, they're pressurised. They're told, well, we'll start attendance procedures if you don't come back to work. We will, if you're off sick again, we will, we're going to sack you because you've been off too much. We need you. We don't have enough people in. You feel. I mean, I was never in that position myself, but I do know that some people would have been, when they were having the management contact, would have felt pressure to go back because the team was under so much pressure, but that's due to staffing problems, not the fault of the individual who's contracted COVID. And unfortunately, if we now know that going back to work too early may have contributed to our developing long COVID because we pushed ourselves too far too soon.
One of the other obvious impacts on people with long COVID is one you've touched on both personally and in your statement, and that's the economic impact on people. Can you, if you're prepared to tell us a little about your own experience, or perhaps just more anecdotally tell us a little bit about what your members have experienced?
I mean, personally, I had to reduce my hours at work, which meant an immediate loss of 20% of my salary. And obviously for those people who, once particularly COVID special leave ended and people went back onto normal sickness, after 6 months, that's the maximum you can get. After a certain period, you drop down to half pay and then you drop down to no pay. Trying to access benefits can be difficult. You can be turned down for them. There can be long waits. My own personal experience, I waited pretty much most of 2023 to actually get adult disability change of circumstances reviewed and awarded. I'm still waiting. I've been waiting now since July last year for industrial illness disablement benefit. A lot of people have benefits turned down, and they're obviously not getting any income from work. And I know of people who are applying for their pensions, medical retirement, and they're not being awarded them. So they are losing significant parts of their income. And obviously, if you are potentially working in the private sector, you may not have that same time frame, because COVID special leave, of course, didn't apply to primary care or whatever. And if we don't have money, we're not paying tax into the system. We also don't have the same spending power, and obviously spending drives the economy. And as well as that, the economy depends on people being fit and healthy and working and so on. But if you have a lot of people who've had to leave public service jobs like the NHS, then that means that lists get cancelled, operating lists get cancelled. There are delays in being seen. That impacts on the rest of society. And we do know from, certainly there was a study in Germany, and they now believe from their data that long COVID is having an impact on the economy, and it's a negative impact on the economy.
Right. You've given us your views on, in the last paragraphs of your statement on human rights. And again, as you're probably aware, the inquiry has a human rights-based approach to its proceedings, but also clearly has consideration of matters of inequality inherent in, and well, indeed explicit in our terms of reference. So all you've said in relation to human rights will be taken into account, and we are very grateful to you for your views on that. Kaz, that's really all that I'd like to ask you at this stage. I know you're going to come back and give us some views on your own personal experience. Like all witnesses, we offer you an opportunity, if there's something that you would like to say to us at this point that you haven't said or you felt perhaps has not come across in the amount of detail or perhaps with the strength that you would like it to come across. So this is your opportunity to do so.
I would like to thank the inquiry for giving a voice to Scottish health and social care workers who are impacted by long COVID. Many are too unwell to participate, and we offer our sincere condolences to those who lost loved ones, colleagues and friends, and we extend our solidarity to all our fellow key workers as well as everybody else in the long COVID community. Many of us have lost absolutely everything: our health, our jobs, our careers and our homes. We've gone from being called heroes to being treated like zeros. We may have to live with COVID for the rest of our lives, and I know many who are dealing with inflexible employers and ways of working, inadequate health and social care, and they struggle, as we've talked about, to access any kind of meaningful financial support, and I believe that's injustice. We really do hope that everybody, and particularly you, sir, do listen to our concerns. We do feel that there are issues that need to be looked into further regarding risk assessment, PPE, RPE. We do feel questions need to be asked about data collection, both previously and ongoing, and information gathering, why people aren't answering questions. This can't happen again on this scale. None of us understand why lessons were never learned from previous incidents like the swine flu epidemic. We don't understand why they didn't take pandemic exercises like Cygnus and Alice into consideration. How could we have been so underprepared, and who is responsible for that? We would like answers. It revealed how marginalised and vulnerable individuals were being treated. Many of us have now joined them, and for some who had pre-existing protected characteristics like race or disability, that's now multiplied. We hope that you will act on our concerns, and we hope you'll gather information on them. And we hope, if possible, when we know the remit of the inquiry, we hope that you will hold these people accountable, because we need you to. Because anything else would be a betrayal of those of us that have to live with this. Thank you.
Yes, one thing I remember noticing in your statement, I didn't ask you about, but I think you've actually made this point. You say at paragraph 40 that you are all grieving for the loss of our health. Does it feel like a grief?
It is grieving.
A loss?
It is a loss. We've lost a huge part of our identities, and we've lost our health. It is grieving, and sometimes, there's 5 stages of it. Anger, acceptance, denial, bargaining. I forget the last one. It's an ongoing process. Many people are starting from scratch. They don't want to accept this is happening to them. But, our careers are, particularly in healthcare, are a huge part of our. And a lot of people only regard individuals by their economic value. And if we can't work anymore, they don't value, which I think is flawed. But that is how see them. They can't be. I can't be the aunt that I once was. I know people that they can't be the parents that they used to be. They can't socialise like they used to. It's impacting every single part of their lives.
Yes, thank you very much. You're the benefits. We're very grateful.
Yes.
Thank you, my lord.
Thank you very much indeed. 3:15, possibly a few minutes earlier.
A few minutes earlier.
That's very good. Thank you. Good afternoon, everybody, and welcome back.
Thank you.
Macaskill. Thank you for coming, I suppose I should say. Yes.
Thank you,
Mr. Gale, when you're ready.
Thank you. Excuse me. Dr. Macaskill, thank you very much for coming back and assisting us. And we have obviously the transcript of the evidence that you've already given. So we're adding that to your statement from the UKI, the transcript of your evidence from the UKI, and we also now have your transcript of part of your evidence from the 22nd of March of this year. Excuse me. I think I ended your evidence with talking about some of the impacts on ongoing treatment of people within care homes, and I think you've given us some information on that, but I wondered if I could go back to some of the, to get a little bit more detail in relation to guidance visiting and also the general approach that one should take to these matters. And I think it was you who'd used the expression gatekeepers as referencing people who were having to determine whether or not somebody should get into a care home and see their relatives or not. You do mention that in one of the first communications that Scottish Care issued was an acceptance of the importance of family members being present at the end of life. Now, that probably seems very obvious, but could you explain why you felt it was necessary to reiterate that in the context of the pandemic?
I think it was very necessary, and together with, if I can remember, Marie Curie and the Royal College of Physicians and Surgeons of Edinburgh and the Royal College of General Practitioners, we issued a statement to encourage essential visiting, to delineate that essential visiting was not just in the latter days of the end of life. It's always very difficult pastorally in a palliative situation to know when somebody is reaching their last days, as they are termed. But to try to encourage people to be aware of the significance of being present, not least when somebody is cognitive and hasn't perhaps slipped to that stage of not being able to recognise and not being able to know that there are people present. The care sector has always, both in care homes and in the community, been aware of the significance of people being present at the point and the moments of somebody dying. And that guidance was, and the stress on essential visiting was re-articulated because I think we had experience of people being uncertain, with all the emphasis on not letting anybody into the care home, of being protective as to what that meant. I had written myself of a scenario where a widow, as she then became, had written to me about what it felt like to hold her husband's hands as he died, as she was wearing a set of gloves. And she pointed out how invaluable that moment was, even though, and how she, in her words, felt his heart through her hands. So we were, and that statement was primarily about encouraging people to have confidence and assurance that this was really important.
Mm-hmm. Who was that communication intended to be received by?
So it was intended to be received by all involved: families, staff, providers of care, public health protection teams, just to underline the significance of a broader understanding of end of life and essential visiting.
In your view, would it have been of use if that qualification could have been included in the guidance that was emanating from government at the time?
I think either that or something equivalent to it would have been useful at the start of the publication of numerous sets of guidance to explain what why it was important and what was meant by essential visiting, because I think many providers deemed essential visiting to be literally the last hours and moments, whereas practitioners in a palliative context know that that's not really all. It is critically important, but it is by no means all that is important.
Thank you. Now, paragraph 29 of your statement, you tell us that as early as April 2020, you were making recommendations that a complete restriction on visiting to care homes was, and using your words, increasingly disproportionate and was failing to meet the pastoral and care needs of individuals. Now, did you make that apparent both to your members and also to the government who were issuing guidance at that time?
Yes, it was contained in a blog which I published and which was picked up by the media and others, so it was very widely known. I didn't probably need to make it aware to our members, not that I'm suggesting they read everything I write, but it was they who were telling me. It was they who were saying, okay, we agreed that it was proportionate, reasonable to achieve the legitimate aim of keeping people safe at the start of the pandemic to close down and lock the doors, literally, because that's what our practice had been. But 4-6 weeks in, the effect of not having family contact, the depression psychologically, the deterioration physiologically of residents was palpable to those who were there at the front line. So I didn't need to tell members about the urgency of trying to do something different. They were telling me. I certainly made the issue very clear to colleagues at government.
When you say you made this clear to members, and perhaps in response to what members were saying to you, were members in the sense of organizations that were running care homes as opposed to individuals and individual managers of care homes, were the organizations as receptive to that advice as perhaps individual members would be?
I might not necessarily make that distinction because, as I think I've said elsewhere in both my statement and in evidence, the majority of Scotland's care homes are made up of small family-run entities or charities. And anybody running an organisation which is larger than that recognises, not least during a pandemic, that your knowledge comes from frontline managers and staff, and if you fail to listen to what they're saying to you, then you're failing to run that organisation effectively. Undoubtedly, there might be different demands on senior managers in an organisation, but I think they were more than sensitive to the reality that closing care homes was having in April and thereafter a really significant impact. And what I wrote in April was that there has to be more to life than simply the existence of the ability to breathe in and out, that there has to be more, and that includes the benefit of having purpose and meaning in your life and a sense of contribution to family and others.
You mentioned that you made this this view that you expressed apparent through a blog that you'd issued. Do you know if this was communicated either directly or indirectly to the Scottish Government, who were the originators of advice?
I am very aware that Scottish Government knew particularly my thoughts and the thoughts of the sector, not just because I wrote a blog, but because I was saying the same things on television and radio whenever I had opportunity at that particular time, and was communicating it in the meetings that I was able to hold with the Cabinet Secretary and in the multiple occasions when we had contact, and it wasn't just me, it was numerous individuals saying, listen, this is having an impact, we need to think really speedily about different ways of keeping people safe. So I don't want to give the impression that there was a cohort of us saying, fling the doors open.
No, no.
And there was a resistance to any contact. But the nuance and the risk aversion at the heart of those making decisions at government, I think, outweighed the pastoral care and concern of those at the ground level. And I've said elsewhere in the statement, I think one of the reasons for that is the structural inability to listen to the care sector and, to some extent, respect the professionalism of those on the ground.
One of the points you've made earlier in your statement is that if you come to your role with a human rights-based approach, and you've said that you had a desire to bring that into your role as the CEO of Scottish Care. Do you feel that there was, with that background, was there any resistance or kickback from your members to the emphasis of the human rights-based approach that you were advocating?
In all honesty, no, I don't think there was. Now, when I say and talk about a human rights-based approach, I'm not talking about creating legal experts in every care home or in every home care organisation, but people who were sensitive, I think I said previously, to the relational dynamic involved. I think there certainly wasn't resistance. There maybe was a lack of knowledge about what did that actually mean. And by that I mean that people may not have been aware of how you can use human rights models to help in decision making, and particularly in decisions where there are conflicting views, because human rights for me in a non-legal perspective aren't about black and white application of decision, but about using frameworks to deal with situations where there may be multiple views. And from that perspective, I think the care sector still, every much as the National Health Service, lacks a full understanding of how you embed human rights in practice. And I've often said that I would make it a mandatory requirement for anybody working in health and social care to have a basic grasp of what human rights in practice means, because it helps as a tool in situations where there is potential disagreement and conflict.
Clearly, with some of your members, there was perhaps an inability to understand what you were saying in regard to the human rights-based approach. Do you feel that there may have been on your part and your role any deficiency in trying to get that point across to your members?
I think it's fair to say, Mr. Gale, that numerous times, and certainly in listening to the evidence of those most impacted, family, staff and others as I have, I'm continually asking myself, could I have done more, spoken more, shouted louder, given confidence to both members and frontline staff, and challenged more effectively? I will leave that for others to decide whether I could have done a better job, but I was certainly very aware of the importance of trying to embed a human rights-based approach. And I was aware that often I was speaking in contexts where people were giving a vocal tick box to what I was saying without necessarily thinking about what the application of a rights-based approach meant, for instance, for visiting guidance.
Do you think it would have been advantageous, either then or now, to have this human rights-based approach embedded in a document that would have been available to all your staff or all your members?
Ultimately, there is no shortage of documentation guidance which mentions human rights, and it's a much beloved phrase of political leadership. but it is the application of human rights in practice. It's the working out of scenarios where there are conflicting views, which doesn't happen in a document or even in a training course, but happens in practice. That's where I think the real gap is, both in the provision and the delivery of care, both in the NHS and in social care. So knowledge about human rights is one thing. Embedding a human rights empathy is, I think, quite another. And that, at a time of challenge, was probably never likely to happen by people reading from a booklet, because the practitioners that I know and came across frequently were embedding a human rights-based approach all the time in the struggles of delivering care.
I take your point, but do you feel that having a referable document that members of your organisation could look at and have, as it were, reinforced by perhaps being a separate document with that heading, would that have been an advantage?
It might have been. Such documentation already existed. I think reference has already been made to the Care About Rights programme, which had been developed by the Scottish Human Rights Commission and which had been rolled out in the care sector. So there were many managers and frontline workers who had begun to think about the conversation of practical human rights implementation. Would a separate document have made a difference in the context of multiple documents? It might have, but what would have really made a difference is the ability to develop relationships of trust amongst local teams between commissioners, contractors, HPT teams, Public Health Scotland, the Inspectorate and local staff. And the deficit of trust and the deficit of professional due regard was probably more of an issue rather than the absence of a human rights-based document.
Thank you. Again, we've heard from a number of witnesses that many care home managers did resort to the constant refrain of "we are only following the guidance" when they restricted or denied visiting. At paragraph 34 of your statement, you say that at local level, staff are consistently having to balance the demands of those who are wanting greater access and those who are wanting to limit it. And I think in brackets you also say, out of a sense of fear. Can I understand what the reference to the sense of fear is, please?
I suspect the inquiry has already heard something of this from frontline staff in the evidence and managers a couple of weeks ago, having watched that. And so in that context, what I meant was that, particularly at the start of the pandemic, particularly in April, and then later on with the Omicron virus, there was a real debate amongst families and individuals who said, you know, we don't know what we're dealing with. Please don't make our family any more vulnerable than they already are. And there was understandably a different perspective of people who were desperate to see their relatives. Now that changed during the course of the pandemic and into 21 and 22. It was very few people who were resistant to opening up. But at different points, and certainly at the start, there was resistance, and the denial of the anxiety expressed by these people, I think, is inappropriate, because they were genuinely worried about this unknown virus coming into the home. It wasn't because they didn't love their relatives or they didn't want to have contact, and sometimes that has been communicated. It was because they loved their relatives and they feared the consequence of an unknown virus that they were worried about access being given. And frontline staff were continually balancing that dynamic, more dramatically at some times than at others.
Yes, I think you've made the point that while we've obviously heard a great deal about the campaigns by various groups, but particularly by care home relatives, about relaxing or facilitating the visiting of essential visitors. You have made the point that there existed also a cohort of people who were very much, for good reasons, in their own mind, refusing or supporting the refusal of access of them to their relatives so as to protect those relatives.
Yeah. And the truth of that statement should not lead us to create a situation of conflict.
No.
Both were desperately concerned about the health and well-being of their loved ones. Both were equally struggling with restrictions, and both groups of people and individuals within these groups were unsure about what was best. Changed obviously as time went by, and I think more and more people were sensitive to the damaging impact of exclusion. But even when I wrote that in April, I was very sensitive to the fact that not everybody would agree with what I had written, because we didn't know about the virus impact, and indeed we had just come through April, through the worst period of death.
One of the problems, I suppose, that we've heard about is that there could be conflicting approaches to the guidance within the same geographic area. So that within Fife, one particular care home could be allowing a more liberal approach to visiting than another. Obviously, for people trying to ascertain whether they could and should be visiting their relatives, that was a problem. Do you see any way that could have been avoided or resolved?
It was a problem. It was equally a problem for staff in those care homes where, for instance, advice by health protection teams in one part of an area, because of a particular approach by a particular individual who ultimately, for instance, signed off a document allowing a risk assessment allowing visiting, was different from the approach of another professional in another part of, say, Fife as an example. Mm-hmm. So staff struggled with the degree of inconsistency and uncertainty. And I think the only way in which that then and potentially in the future can be addressed is if there is real collaborative working and mutual respect, and if the care sector was less done to and more enabled by the whole process of collaborative trust-based working. And in the absence of that, that's what creates inconsistency.
I can see that. That's a perfectly well-reasoned argument. But at a time, as existed in April 2020, where there is no irrefutable body of information or evidence to give an answer, and that may well be the situation in any future pandemic until a time comes when the scientific knowledge has been unequivocally developed, then even applying the approach which I think you quite rightly advocate, the collaborative, trusting approach, there probably will not be any definitive yes or no.
I agree, Your Lordship, and I suppose that my comment was more related to those periods of the pandemic, for instance, later in the year of 2020 and during the Omicron outbreaks in the early part of 2021, and when visiting a risk assessment was being exercised at local level, where the lack of consistency at local level was not helped by the lack of relationship. I agree that at core times with little knowledge of the impact of the virus as we had in the early stage, there was of necessity more likely to be a greater degree of uniformity. But I suppose that comes to the heart of the issue about the application of human rights later on, but also at this time, as to whether or not blanket assessments and judgments were most appropriate, or was there a possibility, or should there be a possibility for flexibility to take account of local circumstance, the nature and specificity of a care home and its residents, and the particular needs of those residents? And certainly we may go on to talk about Anne's Law, but certainly the hope and aspiration of that law, when it is eventually enacted, would be to ensure continuity of contact, even with one individual and one resident.
Thank you.
Thank you. I suppose one, and I'm not suggesting it is one that one should necessarily follow, but I suppose one approach would be to turn guidance from guidance into something more prescriptive in relation to the instruction that was being given, to give less element of discretion.
That is certainly an approach which I think some in the care sector would have valued, because it would have removed any dubiety. But that sort of approach, I think, is only valid if there is consistency in terms of the ability to implement that instruction. So when you have in the care sector, as we had in 2020, a situation where one care home was able to be insured, and their insurer allowed you to allow visitors, and in another part of the sector, insurance could hardly be gained. I came across an email in preparation for today, last night, which was dated early April, in which the provider was saying that on request from the insurance company that he had dealt with for many years, the insurance quoted in early April was 850% more than it had been the previous year. So we may talk about insurance later, but the impact of diverse circumstance, I think, goes to the heart of whether or not you could have a blanket instruction. I think that only works if there is equality in terms of different care homes at different levels.
A blanket instruction let's talk about visiting, and that irrespective of the circumstance, there is an absolute restriction on visiting. Would that fit, in your view, and I ask you with your human rights background, and would that fit with the human rights approach?
In a theoretical sense, no. And I mean by that I think the uniqueness and if I might even say the glory of a human rights-based approach is that it is not the empty application of a rule into a particular circumstance, but rather it's the creation of a relationship in a particular context. And I mean by that I had been used to working with staff in situations where there had been a dispute between a resident, another resident, a staff member, a family member, and the human rights frameworks and models enabled you to use human rights almost in a mediatorial manner. And in that context, that's about not a black and white application. It's about, for each context, analysing the situation, seeing those who are most impacted, identifying which rights might be impinged or impacted, and what can be done to enable an individual to achieve and fulfil their human rights as much as possible. That's, dare I say, much more flexible and loose than simply an instructional approach, which gives no room for flexibility or the creation of relationship.
Yeah, we're getting into a rather philosophical debate here, but
on a Friday afternoon, my lord, I know.
On a Friday afternoon, to use another synonym, a human rights approach is more nuanced and should be more nuanced, and I think we could probably all readily agree on that. And the problem is, of course, that legislation, if properly drafted, does not readily allow for much nuance once it is promulgated. And we're back to the situation when there is no precise degree of knowledge, then nuance is very valuable because it allows, if discretion is granted, or mediation. I like the use of the word mediation in a sentence you used there. It's a mediative process. Frightfully difficult ground. I'm sure all three of us could agree on that, isn't it?
Yes, and that's why I think it changes. So I think I said this the last time, that I have no difficulty in March there being a very definitive decision to lock down care homes because the legitimate aim was literally to keep people alive. Yeah. As the time and the passage of time changed, then I think there were other human rights, the right to privacy, the right to family life, the right to association, and our knowledge of psychological harm, of the impact of restricting people to their own room and space was growing. So other human rights became equally significant. And that's where I think that your Lordship's phrase, nuance, became really important. And my concern then and now is that too often the application of the visiting guidance was too didactic and open to little flexibility rather than it being open to flexibility.
In fact, it could be argued it was rather dangerous because it turned its blind eye to nuance and yet at the same time purported to be flexible.
Yeah.
And it was neither in reality.
Yeah.
Or at least that's an argument.
Yeah, and I would agree with that.
Thank you. Can we move on, perhaps a little from the philosophy to a particular, I enjoyed it, to a particular situation. I think you're aware that there was a meeting in September, it was the 18th of September 2020, between members of the Care Home Relatives group, key members. And they met with the Cabinet Secretary, Jean Freeman, to argue their case for essential caregiver status. You're obviously aware of that campaign. I think you'd had meetings with them in relation to it. Essential to that was the suggestion that a family member or family members should be regarded as part of the care team. Bearing in mind that probably many of those members, many of those relatives had probably been caregivers up until the point when a relative went into a care home. Were you supportive of that?
Yes, I would go further. I think many of those individuals, not all, but many of those individuals continued to be caregivers when the person entered into the care home. And I think you've already heard, but I certainly recognise from staff comments that family is not an irritation, a hindrance, a challenge. They are an essential component of the relationship you want to form in a congregated or shared living environment. It enables, and sadly, unfortunately, there are a significant number of residents in a care home who don't have family or anybody to visit them. And the ability of others to care for, to be present, to contribute to the care and support of their relative frees staff up to spend more time with those who would otherwise have nobody and to focus more. So as an organisation, we were always supportive of the role of family. Now, we might have had disagreements, and I had conversations with Care Home Relatives Scotland about some terminology like a member of the care team, because that immediately might have got us into challenge with regulators around, well, is this a voluntary role as somebody to be registered? But I think the principle of allowing, and that's why I think Anne's law is so significant and why it needs to be implemented sooner rather than later, the principle of having in an emergency situation or any situation, the right of an individual to choose a family member, to be there additional support to the professional carers, and to be present and to be their advocate is undeniable.
I think you've mentioned a couple of interesting points which are, in my mind, first of all, we all know, I'm sure of those of us who've been in the situation of being a relative to somebody who is in a care home, we know that there are very frequently other residents within that care home who never see anybody. Yeah. Their level of loneliness can only be guessed at, I suppose. So there is that situation. You also mentioned in one of your answers that might, if one had a relative as a dedicated or as an appointed member of the care team, however one phrases that, I'm sure we could argue about that, but however one phrases that, you could see that as an advantage in freeing up other members of the in-house care team, if I can put it, yeah, to spend time with people who are on their own.
And absolutely yes, and my experience is also the fact that if you have a relative who becomes part of the community of care in a care home, they don't just spend time with their own relative, they get to know other residents, and in particular, I think we're all aware of those residents in a care home who have no family left because literally there is no family, but also, and maybe more challenging, those individuals who do have family, but that family chooses not to visit or is unable to visit. And I think all visitors to a care home, particularly over a longer period of time, get to know everybody, not just their own particular relative.
Yeah. All right. Can I take you to something that you were asked about in your evidence to the UKI? My Lord, the references to the transcript of the 18th of January of this year, and it's page 164, line 21 to 165, line 15. And if I could just quote for the benefit of everyone. You were being asked by Mr. Tariq, counsel to the I'm sorry, Mr. Dawson, I think it was who was asking.
No, it was Mr.
You were being asked certain questions, and you were asked this question. We know that visitors' restrictions were eased in autumn 2020, but the guidance on outbreaks meant that many residents still faced severe restrictions for many weeks. Do you consider that the Scottish Government's approach on this issue in late 2020, going into 2021 and 2022, did it move towards considering properly the human rights of the residents and their families? And your answer was unqualified. No, it did not. Do you remain of that view?
Absolutely.
Can you explain to us a little of why you are of that view, or why you remain of that view, and were of that view at the time?
So, at the time, we were in a situation where the rest of the country was opened to an extent that we hadn't seen for some considerable period. And yet those in care homes who were by that stage one of the most protected population groups. So we had vaccination, we had rigorous PPE, we had infection prevention and control measures, and so on. And yet there was developed additional restrictions that should there be an outbreak, even with one person, then all visiting would have to stop. And that extent of lack of flexibility, I argued at the time, was a denial of the individual human rights of those residents, because it was treating the residents of a care home as an amorphous group without there being flexibility. And without getting into our previous philosophical debate, I argued at the time that it should be perfectly possible to bestow professional flexibility on the part of care home managers to manage an outbreak in a manner which would continue to allow visiting to happen for those individuals. Now, clearly, if a significant percentage of residents were infected during an outbreak, that's going to lead to a different decision compared to a handful of residents who could be appropriately supported and looked after. Bearing in mind that we're talking late into the Omicron strain, and evidence by that stage had shown significant lessening of impact even on the care home population, as shown by the thankfully diminishing death rate.
Just to complete that reference to your evidence in the UKI, you went on to be asked, why would you say that the Scottish Government didn't move to a human rights-based approach later on in the pandemic? And again, you gave an answer in these terms. I think that the fear of repeating the trauma of the spring and of there being a resultant increase in death as a result of not tightly managing a care environment was an overriding concern. And ultimately, as people kept saying to me, can we live our lives rather than exist in an improved environment, which was a sentiment expressed by staff as much as it was by family residents and carers.
And I would still hold to that statement and sentiment. We had by that stage a population that had been through hell, and the least they deserved was a flexible approach to enable them to spend their last few months. People, I think, forget that the life expectancy of somebody in a care home today is between 14 months and 18 months. Care homes are essentially hospices increasingly in our communities. And I don't know about many people, but if I was faced with the prospect and knowledge that I possibly had 3 to 6 months to live of my stay in a care home, I would be less concerned about getting COVID than I would be concerned about never seeing my family and being able to hold a grandchild or being able to spend time with my spouse. And those were the sort of things that people were saying to us. Those were the things that staff were saying to us, that our colleagues in Care Home Relatives organisation were saying. It was felt to many of us that care home residents had been forgotten as the rest of society returned to what was increasingly called the new normal. And it was because of fear.
Dr. Macaskill, might I suggest to you that having regard to the factors that you identified in the answer to the question, both for the UKI and a moment or two ago to Mr. Gale, and having regard to the other factors at that period of time, whilst I acknowledge the merits in the human rights approach argument that you've been advancing, one could come to the same conclusion as you are using the human rights approach to advance and advocate. You could come to the same conclusion simply by an application of common sense. The stage had been reached when it was sensible to proceed as you suggested. Would you agree with that?
I would, and I would, and further, and certainly said at the time that there is no other context where I think we would make clinical decisions around the well-being and health of an individual which were based on everybody in that environment. But rather, we would, if I became ill, I would hope that I was attended to and that my particular needs were addressed according to my clinical needs at the time. But that's not what we did with care home residents. We assumed and we presumed by blanket implementation of guidance at this stage in particular, which is why I said It was a denial of the human rights-based approach because a human rights-based approach treats an individual not as part of a mass, but an individual in their own right. And that's not what we did throughout a significant part of the pandemic. And moving forward, if we were ever to be in this circumstance again, we cannot have blanket rules and guidance which fails to appreciate the individuality and the uniqueness of each person, and the fact that I may have a year to live, but you might only have a few days.
Can I, bearing in mind what you've just said, and the passages from the UKI evidence that we've looked at, can I take you back, because the context in which you were being asked those questions was autumn 2020 and thereafter, really through to the end of certainly to the end of the period of our terms of reference in this inquiry. I suppose there's two aspects of what I'd like to ask you. First of all, in the early days of the pandemic, so back into March, April of 2020, and in your dealings with Scottish Government in particular, did you see any indication of a human rights-based approach featuring in the way in which guidance was being drafted?
No.
No. Do you feel that it should have done at that earlier stage?
Absolutely. But that would have involved different people being at the table. I think the first time that human rights were explicitly mentioned by government in terms of the pandemic was when, as is referred to in my evidence, and I think others, some of us, including myself, reacted negatively to the then Chief Medical Officer's outline plan for what would happen were resources to be restricted, and the way in which age and frailty was used as a proxy for clinical decision making. And that was the first real piece of work which was undertaken, which included bodies like the Equality and Human Rights Commission, the Scottish Human Rights Commission, and others, and I was part of that process to try to come up with a framework if we got to a situation of having to make a clinical decision about whether one person was treated and another was not. I think the output of that eventually is something which we can be justly settled on were those circumstances to arise in the future, because it was human rights based. But apart from that piece of work, human rights were absent from the COVID response in the early stages.
For the avoidance of doubt, in the second part of the answer to Mr. Gale's question, you mentioned the first time the human rights approach was expressly mentioned. The first part, you answered the question with a very definite no, but I think, I know the answer to this question, I think you would agree that you don't actually need to mention the word human rights approach to display a human rights or apply a human rights approach. Your answer still remains no?
Yeah, my answer was, I suppose, primarily addressing the situation about the care sector, the pandemic, and visiting. The CMO guidance was not explicitly about the care sector. It was about the NHS having to make challenging decisions potentially. So I still hold to the line that human rights was singularly absent, both in terms of their literal application, but also in terms of the behaviours. And most especially, I remember, and I think Ms. Hedge in her evidence recorded this, remember explicitly asking, on a number of occasions, has a human rights assessment been undertaken? And I had the honour previously of working in developing a human rights-based framework for assessing decision-making by public authorities. And it was so, it was something very rarely I knew a little bit about. It was singularly lacking, because it does mean you can't just say, this is a human rights-based approach, you've got to evidence, have you gone through a process in making this decision, in writing this guidance and developing this practice, which is properly human rights-based assessed, and that was not evident at all.
Thank you. Just one further matter at this stage. We will hear from a considerable number of witnesses who represent workers in the care sector. Some of them are union representatives, others are individuals. But one of the points that is made is that they felt that the guidance issued by the Scottish Government regarding visiting and isolation within care settings was drafted without having proper consideration of the circumstances that exist within a care home. Would you agree with that?
Totally.
And I think we can all imagine the situation, those who wander, those who perhaps do not understand the need to keep things clean. Right, can I move on again to something else that you've already mentioned, and that's Anne's Law. You're aware of the proposal that was initiated by the petition in name of Anne, and that's a petition to the Parliament. As the representative of those organisations that would have to implement it, what's your view on what is presently before Parliament in the form of Clause 40 of the bill?
Personally, I fully support it. My organisation does the same, and I have spoken to no care provider who has difficulty with the implementation of Anne's Law. I personally think it's reprehensible that here we are in 2024 in the spring, and we still haven't had that law or something equivalent to it enacted. It suggests a lack of political focus and leadership.
Right. Do you consider that it should be enacted in the form that it presently is, or do you feel that there should be changes to that?
I think broadly the current form, and both myself and colleagues have been involved in the group that has helped to develop and shape it. I think it's broadly in the right territory and is acceptable. I think in reflection to everything I've said earlier, what matters here is not the letter of the law, but how it's implemented and the support that's given to implementation and how we deal with any challenges which may exist, because the implementation of any new guidance or challenge will bring, any new guidance or legislation will bring challenge. So I hope there is an adequacy of resource and there's support for all those engaged, whether family, relatives or frontline staff. But in terms of a piece of legislation as worded, I have no difficulty with it.
Okay, thank you. Can I turn to a matter again you've touched on a little today and referred us to last time you gave evidence, and that's the question of indemnity and insurance. Now, we're aware that the care home sector did not have the indemnity that was available from the government in respect of the NHS. And we've talked about that, but you explain how care homes require to obtain insurance and what risks they are insured against. You've told us about that. In view of the difficulties that you've already indicated, are you aware of any pressure from the care home, I use the word industry, not as a pejorative way, but a care home industry, to have a similar indemnity as the NHS has?
Insurance became a real issue very, very quickly, and what we saw was a huge number of insurance organisations, providers, exiting the market, making a decision that they weren't going to offer premiums. And that lasted. In fact, I came across research which we did in the spring of 2022, and of 16 large insurance organisations, 13 of them were not prepared to offer insurance to a care home. Later on in that year, I encountered an email where a provider was informed by their insurance organisation that they should not admit somebody who was COVID positive, otherwise they wouldn't get insurance. And what happened was, because insurance happens and premiums occur at different points of the year, throughout the year we saw a flux, and very quickly, however, I mentioned in the case of a provider in April, an 850% increase in premiums. Very quickly we began to see a huge spike in premiums. That settled a little bit. Then when Omicron came, it went up through the roof to an average of 500% across the board. That presented massive challenge, particularly for smaller providers. And it wasn't just a fiscal challenge, it was the fact that insurance for any communicable disease was withdrawn. The impact of, had there been deaths in the care home, that impacted on insurance and the ability to find insurance. Whether or not there had been an inspection using a IPC also impacted. So insurance, which had previously never been a major issue or concern for providers, became a very dominant one, including around some of the issues that we've talked about, which were related to a risk aversion on the part of some providers.
Now, this is even not Dr. Macaskill, but you, Mr. Gale. When this issue raised its head, and I don't actually think, I'm thinking particularly of your evidence, Dr. Macaskill, I was interested in it. I think it is important. I received not advice, because it wasn't fully formulated, but it may actually be a reserved matter and therefore falls out with my remit to examine it. Do you have any answer to that question as of the moment?
My Lord, the reason that I'm looking at it is that it does seem to me that the question we are looking at the moment are impacts. We are looking at the impact on not merely those who are in receipt of care, but the givers of care. And those include persons such as the companies, individuals that Mr. Macaskill represents. And also, I think the approach that I was taking to this is perhaps incorporated in the next question that I had from Dr. Macaskill, which is what effect this had on the providers, particularly the smaller providers of care homes. What effect that had in creating a level of uncertainty about their continuation.
Well, I'm perfectly happy that Dr. Macaskill should ask that.
Yes.
I'm interested in it as well. But I think it's only fair to say publicly that whilst I'll consider the matter, and I may say something about it as a matter of impact, it may, I haven't had a definitive answer yet, it may be that if insurance is a reserved matter, I may be very constrained in any recommendations I make in relation to that. Subject to that caveat, go ahead, Dr.
Okay,
Macaskill.
so not being a lawyer and an expert on what is reserved or not, nevertheless, the impact of insurance, which is predominantly and the vast majority of insurance companies are out with Scotland. The impact of insurance was really significant, and I raised it on numerous meetings, and to the credit of Scottish Government, both the Cabinet Secretary and ministers, they sought to bring these matters up with colleagues at Westminster, and on one occasion I was invited to a meeting to explain the challenges and circumstances to the then UK Government Minister Gillian Keegan at that time, and expressed just how significant an impact the insurance issue was. So regardless of jurisdiction, or influence, it had a huge impact on frontline ability and flexibility.
Thank you. I think that's probably as far as I was intending to take it.
No,
Lord, yeah.
no difficulty with that. Subject to the caveat I've already mentioned.
Yes. Right, can I touch on the impact on the mental health, mental well-being of staff and staff morale? Now, you've provided us with quite a lot of information, paragraphs 95 to 103 and 114 to 116 of your statement. Two areas I'd like to ask you about. And again, with the information you have from your members, I'd like to ask you about abuse of staff. And in particular, first of all, the abuse of staff in altercations with those who are wanting to access care homes. Is that something that cropped up often?
It did, but only in a very minimal way. I'm even uncomfortable with the term abuse in the context. I think people were massively frustrated, emotional, angry, hurt, lost because they didn't know what to do, and often because especially in those times when the rest of society was getting about doing their ordinary business, going to the pub, going, socialising, and yet they couldn't see their loved one. That frustrated, understandably, and sometimes people's frustration just poured over and words were said or actions were undertaken, which in all the instances I've known were very quickly regretted. And staff understood that frustration, and where many, I think we often forget that many care staff have relatives themselves in care situations, and they probably felt the same frustrations in different contexts. So I wouldn't necessarily call that abuse, but there was, and there were behaviours which were unfortunate.
Perhaps if I can put it better, expressions of annoyance.
Yeah.
Okay. The other area I'm interested in, and it emerges out of what you say at paragraph 114, where members of staff were accused of letting in the virus. We obviously live in an age of social media. What effect did that have on members of staff? Was that uncomfortable?
Yeah, it was awful because nobody goes to work with an intent to harm another. Staff were putting themselves often in situations of vulnerability and at very real risk, themselves and their families. And there were instances where people were name-called, people were treated aggressively when it was discovered that they were a member of a staff in a care home where publicly was known that there were a significant number of deaths. And I think that is a question to those who engaged in those behaviours, because all those staff were doing was a job of compassionate care. There was nothing more. What I have particular frustration and anger about were those instances I discovered during the course of the pandemic where members of the media, and particular members of the media, behaved in a manner which followed staff home, which one journalist jumping out of a staff member from a hedge, literally, as that staff member left a care home where there had been multiple deaths. So I think there were those who were frustrated in terms of visiting. There were those who engaged in behaviour which is really unacceptable in the community. But what is wholly reprehensible was the treatment of some journalists who don't deserve the name against some staff members, and what that resulted in was a real sense of vulnerability in those locations and for those individual staff members, which caused considerable mental health distress.
Thank you. Can I ask you very briefly about the effect that the pandemic had on recruitment into the sector, and we obviously are constrained by our terms of reference to the end of 2022, so perhaps bearing that restriction on us in mind, are you able to make an observation of how the sector was impacted post the pandemic?
So I suppose it depends what you mean by post the pandemic. I'd want to say during the real key period of the pandemic in the year 2020, early 21, the stability index, as it's called, that's how many people are still in their job a year after the index is assessed, had never been as high, because women and men in the care sector, whether in the community or in care homes, stood up. They were present, they were sacrificial, they were, and I don't like the word heroic because it suggests as if they were superhuman, but they were humanity at our best. And so stability was evidence of that level of commitment. But inevitably, as exhaustion took over, as energy was depleted, people began to reassess, and singularly, without revisiting old ground, the impact of Operation Copper resulted in a significant number of people leaving their posts. And so into 2022, into 23, that stability index decreased significantly, down from the high 80s, if not the 90s, down to just around about 70%, where it sits now. So today, nearly a third of the people working in our care homes were not working during the pandemic. And so and we have the highest level of staff shortage, particularly of nursing, than we have had. That's been addressed in part by the decision in the big start of 2022 to introduce a social care visa, but without going beyond the scope of the inquiry's time frame, that is now being impacted by more recent decisions.
Thank you. Could I ask you just briefly again about testing? You talk about this in paragraph 71 and following of your statement. And I'm interested in what you say at paragraph 73. And one of the issues you mention there is a lack of trust between the organizations or the bodies that were making the transfer and those into whom the transfer was going. Do you explain that a little, please?
I think this was particularly in reference to the decision to discharge a significant number of people in the early stage of the pandemic from hospitals, many of whom were returning to care homes, many of whom could only be supported in care homes. So if care homes hadn't taken them, they would have had no place. What that was referring to was pre-pandemic, the nature of the relationship between receiving care homes and clinical colleagues in care homes and professionals and those in discharge teams. And that relationship was brilliant in some parts of the country and absolutely atrocious in others. And it was atrocious because of a lack of professional regard, mutual understanding of roles, and in some instances a priority in the needs of the person. So discharging people on a Friday night with less than full detail of clinical case notes, with insufficient pharmaceutical support was commonplace, and I'm using that word commonplace before the pandemic. So in that context, and I remember referencing this to parliamentary committees before, in that context there was a lack of trust when the time came in March in particular and into April, and which is why we encouraged all our members that if they were receiving somebody at point of discharge to assume that that person was COVID positive, because the quote, clinical assurance in some instances wasn't worth the listening to.
You go on to talk about a trust deficit in paragraph 75, and then at 76 you say it took some time for the Scottish Government to make a policy decision that stricter measures should be adopted, and for this to be reflected in the guidance from Public Health Scotland, Scottish Care was still addressing instances of post-discharge practices with CPAG, with Professor Graham Ellis and with Hugh Masters in May and June 2020. You're critical, obviously, of the time that it took the Scottish Government to make a policy decision on stricter measures. Can you give a little more context to that, please?
I've stated elsewhere that we, from the get-go, literally the get-go, said to the Cabinet Secretary and clinicians at government that we wanted those discharged from hospitals into care homes, but also into the community, to be tested, and perceived that this population, older individuals with multiple comorbidities, were deserving of equal treatment, and even in a scarce resource situation, as those who were perhaps being admitted into hospital where tests were being used. Now, as I said, even, and I grant that there was a restricted number of tests, I considered that the prioritisation of the NHS at the expense of care homes in particular was not balanced and acceptable, that a different prioritisation could and should have been used. I think what we were equally despairing about was the length of time it took between folks like me raising these concerns and a decision being taken eventually that anybody being discharged from hospital should be tested twice. And the comment there highlights that even when that was made explicit, and the Cabinet Secretary very supportively was standing in Parliament making it clear that this was a requirement, we were finding instances which we brought to clinical colleagues at government of discharge occurring with no testing or less than accurate description of testing.
Thank you. Just a couple of other matters, Dr. Macaskill. Paragraph 51 of your statement, and we're going back to PPE, and we dealt with PPE when you were last here. But one of the points you make there at paragraph 51 is what you call the unnecessary politicisation of the use and of PPE, or failure to use PPE, an unmerited criticism of the sector. And you say, by way of example, statements were made by trade unions suggesting that some independent social care providers were not allocating the appropriate PPE to their staff. Now, before I go any further with that, Dr. Macaskill, we have some considerable information from several union representatives, affiliates of the STUC, which do suggest that that was actually happening. Is that contrary to your understanding?
So I'd want to say that we worked during the pandemic and since very closely with some of our trade union colleagues, so that, you know, because in 9 times out of 10, we're saying the same thing, maybe with a different dialect. Mm-hmm. But it was our experience and the experience of our members at local level that there were instances where local trade unions were acting in a manner to suggest that providers at specific times were preventing staff from getting access to PPE. Now, I personally know of no such instances. What I do know was that the nature of the PPE required in guidance at specific times in the care home sector was not the same as the nature of PPE required of our colleagues in the NHS. So it would appear, to all intents and purposes, that you could look at a care home worker who was not wearing appropriate PPE if your assessment of appropriateness was what an NHS worker should wear. And my colleague Karen Hedge gave a description of how, particularly in the community, there were instances where a nurse or a nurse appeared wearing almost the equivalent of a hazmat, and yet the care worker went in just wearing an apron. So we are very aware, and we've presented evidence to the inquiry of the different stages of PPE requirement, and in some instances, when it was not required to use particular PPE, we had to, and we're in dialogue with unions who were saying that providers were withdrawing PPE or withholding PPE, and that was not the case because it wasn't necessary. I don't know of any instance where any provider deliberately knowing that you should use PPE of a particular nature and who had that PPE withheld that PPE, because why would they do that? I would be interested to see the evidence of the trade unions.
Okay, well, you will hear it in due course. Dr. Macaskill, I apologise. I'd like to, given the time, just go briefly to your lessons to be learned. You provided us with, from paragraphs 117 onwards, with your views on the lessons that you feel should be learned. A lot of these we've touched on in your evidence. But I wonder if I could ask you, sir, to read paragraphs 121 to 123 inclusive, so that we just get that in your own words.
The keeping of provider bodies at arm's length during the pandemic was a critical error and meant that opportunities to benefit from the knowledge and experience of the sector were repeatedly missed. This resulted in an inadequacy of guidance, lack of contextual awareness around clinical needs, for example, residents who had dementia, and the operational realities of delivering care home and home care services. The application of practice appropriate in one area, typically an NHS acute setting, to another area was assumed. The felt presumption of Scottish Government in its guidance was that the social care sector is an extension of a clinical NHS environment, and it is not. It is still the case that the group overseeing pandemic preparedness does not have anyone on it from a direct social care delivery perspective. There is also no equivalent role to the Chief Medical Officer for social care within the Scottish Government. Had it been invited to participate at an earlier stage, I believe that Scottish Care could have helped the Scottish Government to foresee some of the challenges that arose in the care sector, which would have helped to mitigate the subsequent impacts. I consider that it is essential that representatives from the social care sector are involved in future pandemic planning exercises.
Thank you. Dr. Macaskill, as with all witnesses, we invite at the conclusion of evidence to address us on any matters that you feel require to be taken into account or that we haven't dealt with. So I'll offer you that opportunity now, if I may.
I want to thank the inquiry for giving me the opportunity twice now to describe the impact, and there is no substantial matter to raise other than maybe to recall a conversation I had last week with a frontline nurse at an event that I was, 2 weeks ago, at an event that I was attending, who came up to me and said, "The pandemic is not over for me. Every night I go to bed, I see the faces of those residents who are no longer here. And every night I ask myself, could I have done better?" I think she's reflective of the vast majority of providers of care and frontline staff. We are always remembering those who are no longer here and asking ourselves, could we have done better? And we leave it for others to decide that.
Dr. Macaskill, on that point, inquiry is very grateful to you for coming back a second time and for the care that you've given to the presentation of your evidence. Thank you very much, sir.
Thank you.
Yes, thank you, Dr. Macaskill. I'm sorry you had to come twice.
Thank you.
Very good. That's fine.
Thank you, my lord. That's it for today.
I think we're sitting on Tuesday. I'm getting a bit muddled because next week's a bit muddled, I'm afraid.
We are
a
here
couple
on
of days
Tuesday.
where we're not
Well, at
sitting,
least
but I
I
think
am.
we're here on Tuesday.
At least I am, my lord. I hope you will be as well.
Well, actually, I'm not going to be here, but I'll be on the screen on Tuesday. Yeah, and 9:45? Or
Yes,
was it
my lord,
9:30 on Tuesday, in fact? It's 9:30. I was right. Thank you.
Thank you. Thank you.
Good weekend.